Continuing on with chapter 19, whenever we're going to do a physical examination, if our patient is unresponsive, you always want to do a quick head to toe just to make sure that you're not missing anything. In a patient that you're very suspicious of a diabetes related problem, focus on mental status, if they can actually swallow, and then their ability to protect their airway. So we definitely want to obtain a GCS on that patient. We're not going to be able to give them oral glucose if they can't swallow. For vital signs, if you can, based on your local protocols and availability, go ahead and obtain a finger stick glucometer reading. Overall, for patients that are experiencing hypoglycemia, their respirations are normal, maybe a little bit rapid. Pulse is weak and rapid. Skin is typically pale and clammy, and they typically have a low blood pressure. For patients with hyperglycemia, respirations may be deep and rapid and irregular. Pulse may be rapid, weak, and thready. Skin may be warm and dry, and they tend to have a normal blood pressure. For your portable glucometer, they all function relatively the same as far as how you obtain, but there's some slight difference in nuances based on the ranges, how they need to be calibrated, etc. So make sure you know how to utilize your specific service's glucometer before you actually have to use it. Make sure you know what the upper and lower ranges are. And non-fasting adult and child blood glucose range is 80 to 120. Neonates should be above 70. For reassessment, you need to reassess patients that have diabetes or have diabetic problems pretty frequently to see if you're improving their mental status. Are their ABCs still intact? How are they reacting to any interventions that you've performed? Is there need for you to adjust your interventions or not? And then based on the administration of glucose, are you changing that patient's glucose? Is their glucose getting better? For specific patients, especially those that are hypoglycemic, those that can swallow without risk of aspiration. Aspiration is taking in substance into your lungs that isn't supposed to be there. Encourage the patient to take glucose tablets or drink some juice. A lot of juice contains a lot of sugar. You can put the glucose gel inside of that juice, and that'll help them even more. And sometimes that's a little bit more palatable, because eating that straight glucose can be a lot for some patients. The kids love it, but adult patients oftentimes struggle to get that glucose all the way down. So if you throw it in some juice, they tend to do a lot better with it. And then transport to the hospital as necessary. If the patient is hypoglycemic and unconscious or is at a risk for aspiration, you're going to have to call ALS. That patient needs IV glucose or IV intranasal glucagon, which is well beyond your scope of practice. So you need to go ahead and call ALS, and you can do a rendezvous on scene, because once you get that blood sugar up, you may not have to worry about that patient, and they may decide to refuse transport. When in doubt, always consult medical control. For reassessment, if you're unable to test for blood glucose value, that can be very frustrating. So make sure that you perform a thorough assessment. If you need any sort of help, you can always contact the hospital. And then coordinate communication and documentation. A lot of patients will decide to not be transported if they can get their sugar back up. So that can be kind of frustrating, but do the best that you can. I mean, oftentimes they know what's going on. This has happened before. Nothing is new. So just double check on that. So emergency medical care for a patient that is experiencing a diabetic emergency. There's 2 or 3 total types of glucose preparations that are available commercially. There's rapidly dissolving gel, there's large chewable tablets, and then there's a liquid formulation. The only contraindications are the inability to swallow and being unconscious. So you want to wear gloves before you put anything in your patient's mouth, just protecting yourself. Follow your local protocols and make sure that you assess your patient frequently for changes in mentation and blood sugar level, because hopefully it should go up pretty rapidly. Seizures should be considered very serious. That definitely means that the patient is having a rough time since their blood sugar is so low. There's other possible causes of seizures, infection, poisoning, trauma, but the one we're going to particularly worry about is related to blood sugar. Though the seizures typically are not life-threatening themselves, they may indicate that there's some sort of life-threatening underlying condition. The best thing that we can do is make sure the airway is clear, lie them on their side if there's no possibility of cervical spinal trauma. We don't place anything in the patient's mouth anymore. Make sure you have your suctioning unit ready because oftentimes they will vomit. If the patient is cyanotic or doesn't appear to be breathing adequately, provide oxygen or artificial ventilations, and then transport. Altered mental status may be caused from several other conditions, poisoning, head injury, postictal state being right after a seizure, decreased perfusion in the brain for some reason, but can be caused by the complications of diabetes, hypoglycemia, ketoacidosis, the mnemonic that we learned back in patient assessment, AEIOU tips, can certainly help you discern what's going on and why the patient could be altered. Management, again, airway is clear, provide artificial ventilations as needed, prepare for suctioning, and provide prompt transport. Misdiagnosis of neurologic dysfunction. A lot of times patients that are having blood sugar problems look as if they're just drunk or severely intoxicated. So we need to be a little more vigilant. If we end up just sending them with police, they could go downhill very, very quickly. Always try and look for an emergency medical identification bracelet on somebody that is definitely not neurologically with it. If you can perform a finger stick blood glucose at scene, you should do that. The ED will really do more testing, so we can't do. But we need to try and make sure that the patient should go with us rather than with police if they're experiencing a diabetic emergency. And there is certainly potential for diabetes and alcoholism to coexist in the same patient. So yeah, they may be drunk, but if their blood sugar is off on top of that, then yeah, they're going to act crazy. For airwave management, a patient that's hypoglycemic, they may not have a gag reflex. and they certainly may vomit, which could obstruct their airway. So carefully monitor the airway. If the patient doesn't have any suspected trauma, place them in the lateral recumbent position and make sure that your suction is readily available. For hematologic emergencies, hematology is the study of any blood-related diseases. There's a few that we will deal with pre-hospitally. There's several more than this, but typically when we get called, it's going to be for sickle cell disease, hemophilia A, or thrombophilia. Blood itself is made up of 4 components: erythrocytes, which are red blood cells, leukocytes, which are white blood cells, platelets, and plasma. Each part of the blood serves a purpose in trying to maintain homeostasis. Remember, that's that balance within the body. Blood transports oxygen and carbon dioxide into and out of tissues. Those red blood cells, or the erythrocytes, contain hemoglobin, which actually binds to oxygen and carries it to the tissues. Your red blood cells make up 42 to 47% of your blood volume overall. White blood cells, or leukocytes, make up 0.1% to 0.2% of a person's total blood volume, and they collect dead cells and provide for correct disposal, and then of course respond to infection. Platelets make up 4 to 7% of a person's blood volume. They're essential for clot formation. They respond to skin or blood vessel damage and try to stop bleeding, which is known as coagulation. Plasma is the liquid medium of the blood. It does allow for certain materials to become dissolved in it. It has proteins, minerals, and then of course all of our different blood components are floating around in it as well. We're going to stop here. I know it's a little short, and continue on with pathophysiology of hematologic disorders in the next video.